Assalamu alaikum wa rahmatullahi wa barakatuh once again. I would like to welcome all the honorable imams and everyone in attendance for this incredible workshop. The topic of this workshop is, of course, opiate dependence, withdrawal, and treatment for imams. This is, of course, a very important topic. I'm sure you all are very well aware. I will give my personal piece on this in terms of why I believe this is important. In my community, I know that there is a great prevalence of drug use, and the fact that youth don't believe that they can go to their religious leaders to converse about these issues is very troubling for me. But alhamdulillah, I see that the help that has improved in regards to receiving help from imams has drastically improved, and it's incredible. So jazakallah khair for all your efforts in regards to helping with drug use in your communities. But we have a very incredible panel to speak about this. We have Judge Linda Davis, the Honorable Judge Linda Davis. We have Dr. Cynthia Arfken and Dr. Farha Abbasi. So jazakallah khair once again. First, we would like Dr. Samir Ahmed to say a few words.
أعوذ بالله من الشيطان الرجيم بسم الله الرحمن الرحيم الحمد لله رب العالمين والصلاة والسلام على رسول الكريم بسم الله الرحمن الرحيم. Jazakallah khair again for coming here. I asked Dr. Abbasi and Dr. Arfken if I could have 5 minutes from their talk, because as imams, you are often dealing with a lot of tough issues and challenges facing your community. And sometimes, you know, while you're trained in the Islamic sciences, sometimes it's overwhelming with the problems and challenges you are facing and being expected to do everything and know everything. And I wanted to let you know about the Family and Youth Institute. We are a research and education institute, and we primarily focus on strengthening young people and their families, with specific research focus on Muslim youth in the Muslim community, and really helping you identify what are the research needs and what are the programmatic needs that you need. So I wanted to let you know a couple of the resources that we do have. So we have right here infographics, which are taking the research that we've done and presenting it in information that is easy to read. So we have like one on alcohol use, tobacco and hookah use, again, within the Muslim community, youth risk behaviors. Again, these are real issues that our community is facing, and we want to provide you with all the help that you need to get the information out into the community and tell them and let them know these are real issues facing the community. Aisha was talking earlier about the fact that in her community there has been issues with drug abuse, and for a long time the community was in denial that it even existed. And part of what we did was do the research in the community to see, well, what is the prevalence rate amongst young Muslims in terms of drug use, in terms of gambling, alcohol, premarital sex, what's going on? And when we did the research, the next step is really educating people that this is not one or two isolated incidents that we find, and you as imams, you see a lot more of it. But what we want to try to do is help educate the community that there is a real need to discuss these issues. And I thank the Institute of Mental Health and MSU for really having this training for you. But I also want you to know that there are many people who are working to help fulfill your needs. So I wanted to let you know that we do exist. We have resources for you. We have, if you go to our website, thefyi.org, thefyi.org, we are doing research on issues impacting our community. All our research that we've done, we have it on 4 domains, looking at youth development. We've got about 10 studies on youth development. We're looking at healthy marriages. Many of you know Amal Kilawi, who did the research study 2 years back. She's on our team, and we have a number of other individuals looking at different aspects of marriage. We have another group looking at effective parenting and mental health and well-being. And so we want to let you know you're not alone. We're out here to help you. We have research available. We have actually videos available too on different topics and how to strengthen the community. What are more effective programming elements? So I urge you to go to our website and look at that. And the idea is we want to empower you as imams to more effectively meet your community needs. So if you feel that there is an issue that you want to know more about, let us know. And one of the features that we have is we send out articles Monday through Friday, every single day of the week, on different topics. And the topics that we address are generated by the community. We need a topic on this mental health issue. Our community is facing problems with, anxiety, or somebody in our community has bipolar. Can you help me understand how can I teach our community? We provide articles Monday through Friday for you, for your community, free of charge. We also do workshops as well. So we have a number of different resources. I don't want to take any more time from esteemed guests, but I do urge you to email, to check out our website. I will be here all day tomorrow. I can leave my card out here for a little bit in the front. Please feel free to take my card. We want to be a resource for you. You tell us what we need, and we will try our best to get it to you. Jazakallahu khair. Assalamu alaikum.
All right, we're going to have Dr. Arfken speak now. Or Dr. Abbasi first, sorry. Yep, your PowerPoint's on.
Assalamu alaikum, esteemed imams. It's always for me a great pleasure when I see so many imams participating and engaging in mental health initiatives. Like Dr. Samira Ahmed said, mental health illnesses are a reality, and if we work together, we can have better outcomes. Just a thought that addiction is, we have dealt with addiction always from faith perspective, and which is a very, it's esteemed in, it's a reality that it can be a crisis of faith. But now we know it can be a mental or physical health issue. So we know that in our brains there is a reward system, and people who are prone to addiction or have addictive personalities, they do not have enough dopamine in their reward system. And dopamine is your good mood hormone. So if you do not have enough dopamine in your reward system, these people try and get the dopamine from anywhere they can get. So that's the neurobiology or the science of addiction. But we also know that when you are stressed and you are not dealing with your stress in healthy ways, then you tend to deal with your stress with using substances. But we know that if we look at the religion, and you are, and I'm always very careful with Imam al-Turk, that we know that in addiction, in religion, Prophet said khamr, right? I'm saying it right? Anything that creates a state of forgetfulness is prohibited. So we know that religious aspect and we know the science. But why did I felt the need of opiate training? So I recently had a chance to be on a webinar with the Executive Office of National Drug Control Policy and the director, Michael Botticelli, and he has sent a personal letter to you all, which I will distribute in a while. And that opened my eyes. I did not know that we have this big crisis happening in our country. So I came back and looked at the numbers in Michigan. There has been a 62% rise in opiate use, abuse, or opiate-related deaths. So if we look at the drug-related, drug overdose-related deaths, they have quadrupled in the last few years. So what happens is, what is scary about opiates is, it's not like your other substances. Opiates are usually prescribed by your physician. So you might be taking opiate thinking like this is a safe medicine. And without realizing how highly addictive, how difficult it is to get off opiate. So when you take opiate, you have this real good feeling about yourself, about life. You feel like everything is fine, and you start to function better versus other substances. So it might be too late even for you to realize that, oh, there's a problem there. So what happens is, what is scary is that these opiates are being prescribed for minor fractures, like somebody twisted their ankle, wrist fracture, tooth pain. And what happens is they give you a prescription of 30, 60 tablets, 2 refills, and physicians then don't follow up. And these meds, once somebody gets dependent on these meds and don't have access to these, what's the cheaper form is heroin then. And we have a specialist here who's gonna talk more about it. Professor Arfken is here. So when I started looking at the Muslim community, I was scared to find out there is no research, no information available. So Dr. Arfken's studies show that there is a substance abuse problem in the community. There are youth and adults using these meds, but we don't know how many of these are opiates. Or are we even thinking of opiates as a dangerous drug? Opiates, I will just give you 3 medical points and I will pass it on. I'm not going to go through my whole presentation. Opiates only should be prescribed in either malignant pain, like someone suffering from cancer. That's the only role opiates have. There is no role for opiates in non-malignant chronic pain. And what is chronic pain? Any pain that lingers on longer than 3 months. Because what happens is, actually opiates enhance your perception of pain. This is the medicine, the more you take it, the more your perception of pain increases. Another dangerous thing with opiates is it can interact with your other meds. So you might be given something for your anxiety, like Xanax or Ativan, an anxiolytic, and then if you take an opiate, your respiratory drive decreases 6 to 7 times. And if you are a smoker, it further decreases. So more chances of your accidental overdoses. What is really scary is what is happening right now is there are 2 kinds of addictions that are happening. One is people who were prescribed these meds, and second group is people who are using other people's meds. So maybe I was prescribed Vicodin, I couldn't take it, I left it in my cabinet. And somebody in my family saw that, 18-year-old, 20-year-old, and they started using it. They recently told me that when real estate, when you have open houses to sell a house, these youth and young people, they come into these open houses and go through these cabinets to find some meds. Or you might have a party at your house and someone's kid might come and go through your cabinets. And unfortunately in Michigan, we still do not have a program to take these unused meds back. Oh, we do have, there are some, but it's not not lots of them. There's certain areas, I think. So again, that's why I have these experts here, Judge Mathis, and they will talk more, but I wanted to talk more from, because I'm part of the prescribing, I'm a psychiatrist, but I tell you, in my 10 years of practice, I've never prescribed an opiate. And I teach my students, my residents, that please, when you screen for substance abuse, do ask your patient if they are on any pain meds. So another thing is, this is an epidemic affecting more younger age group. This is an epidemic affecting mental health, health providers, because these are nurses, technicians who are around these meds. So what is scary is the deaths that are happening, the number of deaths that are happening. So that's why I thought it is important to have this conversation, and without further ado, I will let Professor Arfken first give you neurobiology of addiction and opiate use.
So is anyone here who could tell me how to get my PowerPoint?
Oh, they shouldn't have left. Okay. I close mine. Oh,
There it
okay.
is. All right. So that was just preserved on tape for everyone to watch. All right. My name is Cynthia Arfken. I'm a professor at Wayne State University. I'm on a national network where we monitor drugs, both the prescription and the illegal drugs. When you hear someone give a talk about drugs, you should always ask whether they have any disclosures. So I am a consultant to the National Institute on Drug Abuse. I'm also a board member of the Detroit-Wayne Mental Health Authority Substance Use Disorder Oversight Board. So one of the things you hear about is the terminology. There used to be a distinction between opiates and opioids and heroin. So now the field is moving to using the term opioids. And opioids are substances that act on opioid receptors. So it's a biological term. And that these opioid receptors then produce morphine-like effects. The receptors are located in the brain, the spinal cord, and the digestive system. So when you take opioids, there are some side effects that come from where the receptors are located. No, that was too fast. Okay, so then you have the two parts. You have those heroin and medications that are derived from morphine. There would be medications that you might know of, for example, like codeine, that comes from morphine. There's also synthetic opioids that are produced. Those would be the hydrocodone, the oxycodone, and those are synthesized. They don't come from the poppy plant. Now, it was already alluded to, why are we interested in opioids? It's due to this tremendous increase in overdose deaths. Here we have two graphs that show the increase in overdose deaths from prescription drugs. As you can see, there was a steady increase to about 2010. And later on, if people are interested, I can talk to you about that. But it occurred both in men and in women. Then in about 2010, you saw an enormous increase in deaths from heroin. So this has been a changing epidemic. It's affecting different groups. And so this is mostly in men, but it also occurred in women. One of the difficulties with these overdose deaths is not all the counties figure out why someone died. So the other thing to do is just to look at all overdose deaths. This is looking in Michigan between 1999 and 2010. So in 1999, we were exactly like the US death rates from drugs, and the US death rates from alcohol. They were all about the same. There's been no change in the death rate from alcohol, whether at the US level or Michigan. But you look at it for drugs, it went tremendous increase, and even more in Michigan than in other parts of the country. This is another graph I showed to say why we're talking about drug deaths. There have been drug deaths all the time in the United States. Back in 1999, there were drug deaths, but it wasn't happening to the people who controlled the media. So now, where you see a tremendous increase in death rates among whites, we're talking about it. And so now you have a case where there's more deaths among whites, a higher death rate among whites than among blacks. This is the poppy plant. This is where heroin comes from. This is where morphine comes from. And morphine is a critical medicine. It's one of the WHO vital medicines that we have. It also produces the poppy seeds that you might have in cakes or on bagels. So it was first produced by Bayer Company in 1898. It was not marketed for pain. It was marketed as a cough suppressant. The leading causes of death then were TB and pneumonia, and they are both expressed by uncontrolled coughing. So Bayer came up with this drug to address the coughing because it suppresses the respiratory system. In contrast, morphine has been around since the 1830s, and that was always marketed for pain relief. They knew about addiction there, and they also knew about the side effects such as nausea, vomiting, constipation. But it was heroin that was banned in 1924, and then the supply was banned in 1956. One of the big differences between heroin and morphine is the group that used it. So heroin was used by young male immigrants. I'm not the one who says it. This is what historians have been saying. The immigrant group were the Irish. And as you can tell, I'm part Irish, so it's important to me. This is what heroin looks like. It can go from black tar all the way to what we call China white. The black tar, you have to melt, you have to liquefy it, and then inject it. It has a very low percentage of heroin in it. The white, the China white, you have no idea how much heroin it has in it. The DEA has found substances that have close to 100% or 0%. And the person who takes it does not know what it has. Now, the closest we had to a big experiment about exposing people to heroin was during the Vietnam War. And I'm sure there's some people here who remember the Vietnam War. But I'm looking around, there's a lot of people who don't. The men were drafted, and in Vietnam, it was easier to get heroin than it was to get alcohol. They were there, they were bored. They estimate, they did a survey, and 45% of the men tried heroin at least once. Of the 45%, 20% developed abuse. The United States was very concerned when we were bringing the troops back. So they said they would set up that the men could not get on the plane unless they did not have heroin on them. So what they had to do was pee into a cup, and from that cup, they tested it to see if there was any heroin in them. 11% of the men failed. They had to detox before they were allowed to get on that plane. Well, researchers studied the men for 3 years, and only 12% of them ever relapsed. So although they had used heroin in Vietnam, when they came back to the United States, they didn't use it. And we can talk about some of those reasons. Okay, there it is. So a question is, will you become addicted to prescription opioids if you receive it? There's different ways of looking at this. There was a study, there's been lots of studies and reports, and this one I took from a meta-review done in 2008. If 1,000 people are taking morphine after an acute injury, an accident, and these people, if they don't have any history of a mental illness or any substance abuse, as well as no tobacco use, and then their insurance suddenly runs out and the morphine is stopped. Physicians should not do that. They should taper you off it. But if you go off it, what will happen is you go into withdrawal. And so people call it the flu, the runs. It will affect you, but it'll go away. That is not addiction. It's physical dependence, but it's not addiction. Of the 1,000, 2 will develop problems. So you could say the problems would be like robbing party stores to get money to buy heroin. Those are the people who have addiction. Now, one of the difficulties is that it has really expanded the people who have been prescribed. As it was discussed, it's not only people who have acute injuries, it could be chronic injuries, it could be that they don't know. In primary care, there's one study where 26% of the people developed addiction when they were receiving prescription opioids. So we're going from 0.2% to 26%. So we really don't know what's going on. It was very briefly talked about the dopamine system. So drugs of abuse target what's called the brain's pleasure center or the reward system, and that's the dopamine. But it's not just the opiates that do that. It's all the drugs of abuse. It's cocaine, it's methamphetamine, it's heroin, it's alcohol. It's also internet addiction, gambling addiction. You see the same pattern. These are patterns from people who have these addiction compared to age and gender matched control groups. So this is a quote from Dr. Volkov, who's head of the National Institute on Drug Abuse. And I tried to pick words that I could communicate to a general audience, and it was very difficult to find. So what happens with these drugs of abuse, you get a large and fast increase in dopamine, and they exceed in intensity and duration those that you get from, for example, eating a nice meal or seeing a nice movie or listening to music. So it also happens that you experience this in a setting that's highly salient. For example, it's someone that you care really a lot about who gives you the drug, that will have more salience to you, and you will have a stronger reaction to it than if a stranger gives it to you. It also depends on where you're taking the drug. If it's someplace that you associate taking the drug with, you'll have a stronger reaction. But the impact of this is that it may reset your brain. It will have a biological impact. And we really can't predict exactly what it is because there are individual differences in response to the drugs. The current model is that it's not just a dopamine deficiency, that it's a complex problem, that you have ongoing neural adaptation, that your brain is constantly being formed or impacted by exposure to these drugs. And there's a network of interacting circuits that work together to do this. And the impact of this is that to treat it, you have to treat all the different systems. That means you have to make the drug less appealing. You have to increase the rewarding properties of what's going on around a person. So for example, if a person's unemployed, to make their environment more pleasurable is if they have a job, if they have some self-worth for what they're doing. We have to learn to inhibit the conditioned learned association. That means, do you know anyone who used to smoke cigarettes and quit? And when they smell cigarette smoke, do they go crazy? And so they want to be away from that cigarette smoke? It's the same way with drugs. You have to get them away from where they will get those cues to reuse the drugs. And then you have to strengthen what's called here the inhibitory control. That means your cognitive sense of who you are, why you're doing it, look at your motivations so that they have the strength to think about it. Are there questions right now before I jump into this other topic about how to treat opioid disorders? Yes?
I have a couple of questions. One, there was a report out by New York Times some time ago, really distinguishing between the more affluent and non-affluent regarding the abuse of drugs.
Right.
The conclusion of that article was that the more affluent white tend to move towards the abuse of what we call prescription drugs. And the less educated, less affluent are moving towards harder drugs like heroin and so on. One would think that it's the other way around. It should be the other way around because more affluent white community, they have at least economically better off. They can get stronger drugs. So could you explain this difference?
All
and
right.
number two, there are occasions in which we detect, there are signs. Could you explain some of these telltale signs that we should look for as somebody comes, and when particularly the youth, when we ask them what's wrong, they say, oh, I have a cold.
Okay. So I'm going to talk a little bit about the treatment. The judge will be talking more about the different experiences, and then we can come back to recognizing the signs. But one of the issues with the prescription drugs is you know exactly what you're getting. They're expensive, but you know exactly what you're getting. So that's why they're more common in the affluent, because they want the high quality. In the urban setting, which heroin never disappeared, that's what was in their environment. Does that make sense? That you don't go into a store and buy heroin. Now there's systems set up that you might be able to call someone to get your heroin, but usually it's introduced to you by someone you know. So if heroin is in the network, that's what you're going to be introduced with, too. Right.
I don't mean to steal your
No,
thunder,
no, go
but
ahead.
a lot of the studies that you've read on this are studies that are somewhat outdated. Drug use now is pretty much equal across all economic levels and cultures. So it's really important for you to understand that the Black community is using prescription drugs. They're also using heroin. They're also using marijuana and cocaine. I'm sure in the Muslim community you have a cross-section of those same drugs. The only difference is that a lot of the street drugs used to be in the more urban areas, the bigger cities, the less wealthy people. Those are no longer the cases. They have spread to the suburbs now, and it's the rich, the poor, the middle class, and it's just whatever they can get their hands on. A lot of the addiction starts with very legitimate reasons, that a tooth being pulled and your doctor prescribes you Vicodin, or you get injured playing a sport and you get prescribed Vicodin or oxycodone or morphine or hydrocodone. Those are exceptionally addictive medications, and I'm going to talk a little bit about that when I give my talk about how we got in this mess. But it really is pretty equal amongst all communities now. So a lot of those studies are really outdated, and I think if you start looking at what's going on in your community, you're going to see that it's the rich, the poor, the middle class, that it is pretty much crossing all socioeconomic levels and all cultures at this time in the United States.
So for example, in Wayne County, 45% of the people in treatment for substance use disorder are for heroin. 5% are for prescription drugs. So yes, the heroin and prescription drugs are everywhere, but it's higher in cities which had more centralized, but it has spread. So 10 years ago, you did not see heroin throughout Michigan. Now you do. Yeah? The powder cocaine, right.
So it was always the affluent had access to pure cocaine, and they would pass the trash to the neighborhood. Number two, in the 60s, they were passing out heroin in the high school bathrooms for free. So that's the other, in the 60s.
Right.
That's how a lot of African Americans got hooked as well. So some of it was like sociologically induced by another class, you know, for a reason.
Right. And there's also, it's around, so you knew people who would use it and they were your friends.
Yes.
There are differences in the use that in the African American community, it was unusual to inject the drug, whereas in the white community, it's very common to inject heroin. So there are some differences. Got it?
I just have one request. We would have a question answer session. I was just hoping to, but please go ahead.
This is going to be very quick comment just because it relates directly to the question. So my name is Gada Abdallah. I'm a pharmacist, and I just wanted to make a quick comment on how we got from pills to heroin, because prescription pills were prescribed very liberally throughout the 90s and early part of 2000 up until now. Actually, yesterday, the Center for Disease Control issued new guidelines so that we don't doctors don't easily give out prescriptions for addictive medications. But what happened is Vicodin came off the market, and now there's another drug called Norco. It's exactly the same, but it has less Tylenol in it. And if you don't have a prescription for Norco or Vicodin, you can still call it Vicodin, it's going to cost you about $10 a pill. And some people are taking 10 pills a day to feed their addiction because maybe they got a prescription for something when they were in a car accident, like Dr. Arfken said. And so now, instead of paying $3,000 a month to feed their addiction, they're turning to heroin. And there are types of heroin that doesn't have to be injected that they can use, and it's much, much cheaper than than prescription medications. And so that's why we are in this crisis right now. So.
Right, so there's been a tremendous increase in supply as well as demand. I want to do very briefly how to treat opioid use disorder, just so that we get some terminology, because I know that she wants us to move ahead, and the judge has her presentation. So since 1965, methadone has existed as a medication-assisted treatment. I talked about these opioids fitting into the opioid receptors. That's what methadone does. It occupies the receptors. It has a slow increase. It stays there. It's been used since 1965, over 50 years. We have a lot of experience with it. The benefits include reduction in death rates, reduction in injection drug use, a reduction in crime days. I know police who are on methadone. I know judges who are on methadone. and reduced HIV seroconversion. People can work when they're on methadone, but when they go off methadone, what happens? They relapse. They could die. Now, not everyone goes off heroin or prescription opioids when they're on methadone, so it requires more things. Another one is buprenorphine. So buprenorphine is a partial agonist, and there's also something called naltrexone, which is an antagonist. So buprenorphine, I was involved in the initial marketing to look at the surveillance of it to see if it was being diverted and abused. It has less analgesic effect. It has less impact on the respiratory system, which translates into fewer deaths. And it's been around since 2002. It has the same issue as methadone. You have to be on it for it to work. When you go off it, people relapse. So it takes medication assisted is for what I talked about is reduce the reinforcement effect of that medication. But drug treatment has to be a lot more than just medication assisted to be successful. And then the last one is naltrexone versus naloxone. Naltrexone is used for chronic prevention of overdose. Naloxone, which hopefully we talk about, Narcan, is used for the acute treatment of overdose. It's extremely important, and it's been totally underused in Michigan. It's much more common in other states. It will reverse it if someone has an overdose for an opioid. It will not reverse it if they have an overdose of alcohol or cocaine or sedatives. So this is one of the ones I borrowed from Carl, is why do we bother to treat addiction? It has an impact on the individual, the family, and society. Drug dependence is a chronic medical illness. Only 60% of the people with type 1 diabetes adhere to their medication schedule. It's estimated fewer than 40% of people with asthma adhere to their treatment regimen. And 40% of people with hypertension adhere to their treatment regimen. In drug dependence, if you look across all the different ones, it's about 40 to 60%. So it's very similar to other chronic diseases. If you had an addiction, if you had diabetes, and you were to stop taking your insulin, and you wound up in the ICU, your doctor would say, you need to go back on insulin. You could have died. If you were to stop methadone, Suboxone, or stop going to your counselor, and you wound up in the ICU, your doctor would say, you're an addict. You're hopeless. And hopefully from this, you know that treatment now, addiction is like other chronic diseases. It is preventable. And I very strongly believe that prevention is key for every community. It is a moral issue to decide to use drugs. But once someone has started using drugs, then it becomes a medical issue. It is treatable. It changes the biology of the person's brain. And if it's untreated, the addiction will last a lifetime. These are some of the resources available to you in Wayne County. To get someone into treatment, there's one telephone number. Please call it. If you want to learn more about drugs, that is in what they call Easy Read. It's easyread.drugabuse.gov. It covers drugs that people abuse, the effect of drugs, what is addiction, how to prevent drug abuse, and what is treatment and recovery. So thank you.
All right, next we have Judge Linda Davis. She is from the 4-1 court. 41B court, sorry. I think I'm tired. So everyone, please welcome Judge Linda Davis.
Thank you. I sit behind a podium all day, and it's so impersonal that if it's okay with you, I'll just stand here and talk. And that way, if you have questions, I'll be able to hear them and hopefully give you some of the answers. This became a problem in the United States, and I wanted just to take a few minutes to explain how we got to this point, because it is an epidemic in the United States. We lose one person every 12 minutes in the United States to a drug overdose. 47,000 people last year in the United States died of overdoses that exceed the number of people that were killed in traffic accidents. And it's the first time in the United States history that occurred. It used to be that a lot of our drugs came from overseas. Most of our drugs, the heroin that's coming into our country now, is filtering in through Mexico. And that happened very methodically by the Mexican cartels. What was happening is about the year 2000, there was a group of doctors out of New York City that started doing, they said they were doing experimentation with opiate drugs. And opiate drugs are things like Vicodin, oxycodone, hydrocodone, and they're listed in that little brochure that I gave you. They have almost the identical same chemical makeup as heroin has. If you took an atom of Vicodin and you laid it on top of an atom of heroin, they match almost identically. Well, we as a community did not know that that's what we were taking. If you went to your doctor and he said, look, I'm going to give you 30 Vicodin because I just pulled your tooth and you might be in some pain, you probably wouldn't think much of that. But if he said, here, I'm going to give you 30 pills of heroin, that might get your attention. But we were sold a bill of health that those drugs were safe and they were not addictive, and they're highly addictive. And if you take them over a long period of time, you become addicted, and it can lead to, you can become dependent, and it can lead to an addiction. Well, in the United States, we take more pills than any other country in the world. We consume 97% of all Vicodin or narcos that are written, and we only make up 4% of the world's population. So there is an abundance of these pills that are in the United States. We take 90% of all opiates that are produced worldwide, and we still only make up 4% of the population. We've really become a pill-popping community. I'll give my age away by saying this, but when I was a young girl, we had one pharmacy in the city that I lived in, and it was on a major street, and when you went in, there was a shelf about the size of this table, maybe a little bit higher, and it had 3 shelves on it, and all the medications that you could get, prescribed and non-prescribed, were on that shelf. Now we have a drugstore on every corner, and there are rows and rows and rows of non-narcotic medications, and then the ones that are stronger, there are rows and rows and rows of those behind the counters. And we've gotten so we take pills for everything. We don't want to feel as a community. We take pills to wake up and be energetic in the morning. We take pills to go to sleep at night. We take pills to make us happy. We take pills to bring us down from being too happy. We even take pills when we get at the age where we should slow down functioning sexually. We take a pill that allows us to do that way beyond what God ever intended. So there are lots of pills in the market, and our young people have incredible access to them. And so we as a community, we need to change that. But these doctors went around and they trained other doctors. They would send their pharmaceutical reps in and tell doctors that, oh, these prohibit pain and they're not addictive, and only 1% of the population could ever get addicted from them. But those studies were bogus studies, and those doctors have all been indicted now, every single one of them, because they did not do studies that were credible scientific studies. The new guidelines just came out by the medical society, the National Medical Society, that says, number one, It should never be a first choice of medication. Secondly, that it should only be used in extreme cases, and if you are taking it, it should never exceed 72 hours. So in the worst of cases, and we have an organization, I'm going to talk a little bit about that too, but one of the doctors that's on our board is the Red Wing doctor, and we all know who the Red Wings are, right? He is the doctor for the Red Wings, and they totally have banned the use of any pain medications that are an opiate base. Now, who gets hurt more than a hockey player? And yet they treat their pain with ibuprofen and non-narcotic pain medications. But we've gotten so we want instant gratification. We don't want to just manage pain, we want to eliminate pain. And when you eliminate pain, the medications are so strong that they are very addictive, and that happens very quickly. And then you add to it that these medications are being given to our young people. A lot of our athletes, 72 people who form addictions start with a legitimate pain prescription medication. That's a huge number of people that get addicted, not because they're out experimenting, but because they legitimately had an issue that their doctor wrote a prescription for. So it's really important that you challenge your doctors and say no when they're writing these prescriptions to you, because they're dangerous. But they're being given to our young adults, and their brains are not developed yet. So they get dependent on these drugs much quicker than a mature adult whose brain is already formed. Senior citizens also get addicted much quicker than a middle-aged person would get, because you know how they say once an adult, twice a child? Well, you start losing some of your brain matter, your ability to put things together. So as you get older, these drugs affect you very differently than they do someone that might be middle class. But it might be interesting for you to know that most deaths occurred in the United States between the ages of 32 and 47 years of age. And that's because we have a lot of blue collars workers in Michigan that get hurt on the job and they get injured, and they're prescribed Vicodin or oxycodone or one of the opiates as well. And they are just as susceptible to anybody else to become dependent on these drugs. They temporarily make you feel great. If you talk to someone that's addicted to opiates, they'll tell you, wow, you feel no pain. You don't feel any emotions either. So if you're depressed about something and you take it, it kind of flatlines you. You're deadened. They sleep a lot. They get lethargic. All of those kind of things happen because it is meant to numb you. And lots of young people are under a lot of stress. We live in a very stressful time in the United States. They're under a lot of stress, and they like the feeling of not feeling anything. So one of the things that we in our community did, about 9 years ago, we had a rash of deaths that occurred. We had 9 young people under the age of 25 that died in a very short period of time of heroin overdoses. We had never seen that in our community. Before I became a judge, I was a prosecutor, and I ran our drug prosecution department, and I saw one heroin case in the 13 years that I did that. And then sitting on the bench, it became commonplace that I was seeing them day in and day out. One young person after another who had never been in any trouble was coming into my courtroom on a theft crime. And I started asking them, what's going on here? You've been a good kid, you've never been in trouble, and now all of a sudden you're stealing baby formula. What is that all about? Well, baby formula is hot on the market. They can turn it over quickly and get quick cash for their next fix. And almost all of them across the board started telling me, I'm addicted to opiates. I'm either addicted to prescription drugs or I'm addicted to heroin. And then I had my own personal story. I had a 17-year-old daughter 8 years ago who was an incredibly lovely young lady. She's very pretty, model pretty, straight-A student, had been accepted to every college that she applied to. She was a senior in high school. She did competitive cheerleading and traveled all over the country doing cheerleading. And I heard her in her bedroom crying one night. And I went in, and we were always very close. I thought I knew her very well. I thought I knew everything about her. She had started dating a young man that I did not approve of, and we had many battles over it. But she was 17, and it's hard to say you can't see this young man because they sneak around and do it anyhow. And she did. And I heard her crying, and my first thought was, oh my gosh, she's pregnant. And that was mortifying to me because she had a bright future ahead of her, and I certainly didn't want her to give up her future to start a family at 17 years old. And when I questioned her about it, thinking that's what was going on, she told me no, it was much worse. And in a very short period of time, it unraveled that she was addicted to heroin. Now, I did not think that could happen in my family. We have a good Christian home where we go to church all the time. I was with my child all the time. I've never neglected my children. There was no big trauma in our family. She was never beaten. She was never sexually assaulted. All the things you think create drug addiction, none of those things existed in my family. But for the next 3 years, I watched her battle her addiction, and I literally was watching her die. She got down to 86 pounds, soaking wet. Her eyes were sunk back in her head, and I was sure that every time the phone rang, it was going to be that phone call telling me that my daughter passed away. I couldn't go to funerals for friends. My friend's father died during that time, and I couldn't walk into the funeral home because all I could see was my daughter laying there. And it was painful. And addiction affects families as much as it does. I think sometimes more it affects the family than it does the person who's getting high, because they just go out and numb themselves getting high, and we have to watch it all happening, and we really have no control. Well, I'm one of the fortunate parents because we got her into the best facility. She got lots of treatment. We prayed like crazy for her. We were there by her side every step of the way. After 7 treatment facilities, she finally got clean, and this June will celebrate 7 years of sobriety. But I became passionate about this because I realized that if this could happen to me, it could happen to anybody. And I'll tell you that when this first happened, I didn't want to tell anybody about it. I'm a judge. I have to get elected by people like you who are going to vote for me. And I thought, oh my gosh, if this ever gets out in public, I'll never get elected again. They'll think I'm a bad mother, that I did something wrong. I beat myself up terribly. What did I do wrong? Where did I go wrong? What could I have done differently? And the fact is that this is a brain disease, and it has nothing to do with anybody who has a child that's an addict in their family. It's a chemical thing that happens in their brain that they don't have control over, and trust me, neither do we. It takes treatment. It takes a lot of prayer, and it takes a lot of treatment to get somebody off of opiates and into the world of recovery. So in my community, and I was a big part of this, we started an organization called Families Against Narcotics. And we started taking young people like my daughter who were getting it right and were being successful in their recovery, and we started taking them into our high schools to talk. Because we truly thought when we started this organization that this was just young people that were trying to have a good time. And young people do that. They rebel against us. When I was a young kid, it was drinking beer. I didn't do that, and that's the honest to God truth. I did not drink beer when I was a young girl. My father was very strict. I was afraid to do anything like that. And so I was older before I had my first drink, but all of my friends did. They drank beer, and then it became mixed drinks, and then marijuana came on the scene. And then it became the hallucinogenics, the LSD. And it's kind of a rite of passage for young people to experiment with those things, to step outside the bounds of what their clergymen or what their moms and dads tell them is right and wrong, and kind of flex their muscle and feel their oats and figure it out for themselves. And then after the LSD, it became the cocaine that you talked about, sir, and the crack cocaine, which was very, very addictive. But then when prescription drugs came on the scene, it changed the makeup of addiction. Because all of those things that I talked about before, with the exception of crack, that's very difficult to get off of, but all of those other substances, kids can use those through high school and through college, and decide, you know what, it's time to grow up, I've had enough. And with a little bit of work, they can usually come out of that. Not everybody, but a large, vast majority of people can come out of it. With opiates, that's not the case. They're deadly. So we wanted to teach kids this, that these drugs are different than other drugs that kids experiment with, and these you need to be safe and be very careful with them. And we really thought when we started it was just young kids experimenting, trying to feel their oats, flex their muscles a little bit, and they were getting into things that they didn't understand. But it didn't take long for us to figure out that it really was a doctor-perpetuated addiction that was going on in our country. About the same time that these doctors were teaching other doctors that these medications were not addictive, we had pharmaceutical companies that lobbied in Washington, D.C. to get pain management as the 5th vital sign. Now, vital signs are things like your blood pressure, your heart rate, your temperature, things that you can measure that are measurable things. Pain is not measurable. It's very subjective. What I think is pain, you might not think is pain. My endurance might be better. So we let people start kind of saying what they needed when they went to the doctor. Instead of the doctor telling us what we needed, we were telling them what we needed. No, I need stronger pain medications. And then, because it became a 5th vital sign, reimbursements to hospitals and doctors were based on how well they managed pain. So there was a whole lot of things that happened all at one time. But the Mexican cartels were watching this in the United States, and they saw this big influx of drug use through pain medications taking place, and they started putting opiate dens, heroin dens across the United States. And if you want to read about that, there's a book called Dreamland that outlines this progression of how opiates got into the United States at the level that they are right now. But we have a huge problem, and it's up to us as a community to deal with that. And trust me, it's not something that people like to talk about. We call it the silent epidemic because drug use in the past was something to be ashamed of. I certainly was. I was not proud that my daughter was a drug addict. I was not proud that she made bad mistakes and took a road that I would have never wanted her to go down. But she was sick, and she needed my help. And it really opened my eyes up to the fact that these are not bad people. I work with hundreds of young people that are in recovery every year, and they are as good as any child you could put up against them. They're college-bound. A lot of them have graduated college now. My daughter has gone to college. She's working in a treatment facility. These are people that can be productive human beings if we help them navigate the system and get into recovery. So we started this organization. We not only then went into high schools, we started teaching doctors. We got doctors on our board, and we did presentations. And all of our videos, and I would really encourage you to watch some of them because they really are eye-openers and will teach you a lot about addiction and what families go through. And they're all on the website of familiesagainstnarcotics.org. But then we wanted to do even more. So we came up with, we came up with a group of materials that we put all over our community. And some of them were posters telling you to get rid of your unused medication. We started telling people that it's not okay to share your medications, that if you're written a prescription for something, Xanax or Vicodin, that's not safe to share with someone else because they may get addicted to it. You may be doing that person harm, so you don't share them. If you do have those kind of medications in your home, treat them like they're loaded guns and lock them up in a safe place. And then when you're done with them, dispose of them. And we listed all of our disposal sites. And somebody asked, where can we get rid of medications? If your team up here will find out where that's at, we can have these printed for you with your information on the bottom of where your disposal sites are. A lot of pharmacies have them, and most police departments have disposal sites now. No questions are asked. You just walk in, you put them in a plastic bag, you throw them in a receptacle, and they burn them. So there are a lot of things that each one of us can do in our community to make a difference. But talk to your children, get the medicines out of your home. And if you notice the signs in the brochure I gave you listed some of the signs to watch for, don't think you can deal with this on your own. I almost killed my daughter trying to love her through her addiction and keeping it a secret. It's nothing to be ashamed of. Ask for help. Okay, thank you very much.
So it's in the brochure, signs and symptoms, but I can tell you briefly. Opiate withdrawal is the most painful withdrawal. So somebody can appear really sick. They have severe body ache, severe stomach cramping, shivering, rhinorrhea, nose running, eyes tearing up, diarrhea. So it's a very painful, but they will come out as looking very sick. But one thing I want the take-home message is, you never fully recover. You might be sober for years and then somebody shows you heroin, or you are in a place and it takes one overdose, like when you take it after a long time, like we saw the famous actor Seaman. He overdosed on heroin. So they're always in recovery. Another important thing is they might be on methadone, they might be on something else, but still they can overdose on heroin. So I am going to print out a withdrawal scale that we use on our patients, and we are just printing it out, and I will give it to you all. So those are the few things to remember. But the most important message is addiction. People who are addicted, they learn the art of deception. So they might appear to be doing well. I was with Richard Cizik, he's a big clergy, and with me on the webinar. And he talked about his son was prescribed Vicodin for a sport injury. Very, like he was also a very good student, athlete, and next thing they know, he started using heroin. So he was sent to rehab, and he was home for holidays, and they thought he's all clean and done with it. And he got a call from his person, whoever was providing heroin to him. He told the father that I'm just gonna be back in a few minutes. And next thing they know, they found him dead in his room. So drugs don't discriminate. Substance abuse don't discriminate. Keep an open eye. Anybody who starts isolating, start acting differently, start behaving oddly, just keep an open eye. And then more important is keep an open attitude. Thank you. Any questions? Yeah, please. Yeah. Can you give the mic?
And that is, when you mention the fact that a lot of these ads that are on television that tell people to go to their doctor, ask for this drug, that drug, and then they give a list of 15 side effects. The last one usually being suicide, you know. There's talk going around in Lansing, in the legislature, about introducing a bill that removes these types of ads from the television and from the media market. Would you support a bill like that?
Absolutely. 7 out of 10 commercials right now are drug-related commercials that show butterfly flying through fields and give you that euphoria feeling. We banned them advertising tobacco and making it a fun thing to do. We need to do the same thing with pharmaceuticals in our country.
Right, we do.
Thank you. Who's doing
I
this?
have a question for the judge. It was an excellent panel.
Thank you.
Where are we headed as a country? We speak about alcohol addiction. I heard about the number of people killed in alcohol-related deaths today, but if you go in CVS, Kroger's, there are more liquor aisles than there are food aisles. What is happening nationally? What do you think is going to happen to this society?
I think there's a lot that's going on now. I served on the governor's task force this year to deal with this opiate problem, and there's a lot of legislation that's being passed right now to help us get us on the right track. We're going to start monitoring doctors better. There's a bill going through right now to revamp our where the doctors put into a system what they're prescribing. That's going to be mandatory that they do that. Right now it's kind of a voluntary system so that your doctor will be able to look to see what other doctors have given you. And it's also a way of us monitoring to see which doctors are abusing those prescription privileges. I think drugs, we've partnered with Kroger, St. John's Hospital, Henry Ford Hospital that are putting right on their pharmaceutical bags that opiates are dangerous, to take them sparingly. So there are a lot of positive things that are happening, but we didn't get in this mess overnight, and unfortunately I think it's going to get a lot worse before it gets better. But we just all have to keep doing what we can to move it in the other direction.
And move our politicians to get something done.
Yes.
Yes.
Oh, I'm sorry. I
Yes,
didn't see
ma'am.
what you read.
I'd like to ask a question about the spiritual aspects of, since this program is mostly for imams and spiritual leaders.
Right.
And I wanted to ask a question about the role of spirituality or religion in stopping addiction. The reason I asked that, years ago I smoked for 25 or 30 years. A few other things too, but we'll concentrate on the cigarettes now. And my friend and I were both becoming Muslim at the same time. And we were working, and so it was the day before the Ramadan started, the first Ramadan. And so I told him, I said, listen, tomorrow is Ramadan. You can't smoke. He said, yeah, that's right. So before then, I could never quit smoking. I mean, that's for many, many years, and I always had these cravings, but when I did it for God, I didn't have any withdrawals, no signs of it. And I mean, it was just amazing to me and I haven't, since that time, I have not even had a desire for cigarettes or anything. So you showed a picture of those, the brain scans up there, and I want to know what role spirituality have you all went through that, and what role spirituality would have in stopping addiction?
There definitely is a spiritual part of addiction. It's like the psychologist said when she was talking, there are a lot of components to addiction. It needs to be treated physically, but people that become addicts are spiritually bankrupt as well. And so and I will tell you that the young people that I work with almost always return to a God, a spirituality, when they're getting on the road to recovery. So I don't want to underplay the power of prayer. I did an awful lot of bending on my knees when my daughter was going through her addiction, and it is a big part of what family and the community can do to support the young people or the older people that are addicts, is to pray and pray profusely for them and pray with them. But until they start dealing with the physical and some of the other aspects of this, they aren't able to focus on the spiritual, and that's why it's so important to treat the whole person and not just a portion of it. But you're absolutely right, the spiritual is a big part of this. And that's wonderful, and I don't mean to underplay that at all, but we're all different. And I try to be a very spiritual person myself, and then I'll find myself forgetting to pray for a day or two, and I have to get back on track, and not everybody is able to maintain that. So we really have to treat people as individuals and realize that you're strong enough to do that, and you've got that belief enough to be able to do it, but somebody else might just not be there yet. They might get there, but they're not there yet. And so we just have to do all we can in a comprehensive way to make sure that all parts of their well-being are being taken care of. Feel free to jump in.
Your Honor, thank you very much for the frank conversation and discussion. Within, at least I speak on behalf of my own community, unfortunately, due to a degree of resentment that exists to admit that there is a crisis to deal with, we either have as imams to work as detectives, literally, when it comes to the issue of youth, to try to find out whether there is such a thing. Because if we don't, the only time we hear about it is when the family calls us and they say, Imam, would you be prepared to recite something because my child or somebody from the family died yesterday? That is a sign in itself that there is. I have spoken to a number of youth that they are involved with leaving. So is there a website? I know that they just gave us something, a list of signs that we as imam, when we go to people's houses or when the youth come to us, we ask, or if the parents come to us and they said that there is an issue, these signs can be used to detect one way or the other that there is a degree of either drug abuse, prescription abuse, or whatever it is. Are there such a thing, or is there a site that we can go and find out?
Yeah, our website has a lot of that information on it. You can also go to drugfreeamerica.com. That's a really good one to direct youth and parents to. There is a lot of that. And every time you click on one of those websites, it'll give you 10 more that give information on this. This is such a big issue right now that there is a lot of information out on the network about it. But start with ours and it'll direct you to a lot of other websites, or drugfreeamerica.com.
Or the one I showed, easyread, drugabuse.gov.
Okay.
Yes, ma'am.
Okay.
Yes. Okay, I want to say a couple of things. In reference to the differences in people, you have two types of people. Those who have the support group from humans. Josh Hamilton, baseball player. And he's fought with his problem. He's failed a few times, but he keeps fighting. What I have learned, and me being personally affected by the drug scene myself, every drug you name, I took predominantly. At 18 years old, I left it. You have two types of people. The one who depends upon humans alone, and the one who makes a covenant with his creator. I was the beneficiary of that in 1979. And I say that because I heard the other speakers say that you never really get cured. Well, I've been 37 years cured. And it's not, I'm at the point of return. It's not going to happen again, by God's grace. And I'm saying that because when you look at drug treatment centers, in the end, they try to get you to have faith in higher power. And this is what is missing in the intellectual world as relates to psychologists, psychiatry, all that business. We unfortunately try to deal with the human element with only the human element. And I'm just saying that so in the future you would have reference to say that look at the human beings that have been constant in the full human being set, that is the physical, the mental, the spiritual. Right. There has to be a balance in play in all times. Right. Because we are more than just intellectual or a physical person or a spiritual person. It has to be together. So it's encouragement to those who may be fighting something and those whose families are going through troubles. I'm saying that for sure, without doubt, when you make a covenant with the Creator, it's done. There is no going back. Thank you very much. Oh, and the spiral effect. You mentioned about the marijuana. Marijuana, for some, marijuana, it actually will send you to the next level up. That's what happened to me because of bad environment. And so you try this and that because this drug stops working. So you have to take the next one. And then you do a combination. I'm telling you my story without telling you all the details. So there's a spiral effect if you don't have, like you said, Judge, a support group to really take you out of that environment that's taking you away from your true self. So you did a great job as a mother trying to stay on top of it, you know, but everyone doesn't have access to that. Right. So it's always, like you said, two stories. One Absolutely. With the help, one without the help.
Absolutely.
Thank you.
Sure.
Just a quick announcement before the imams leave. So we are serving dinner. Since the session was only for imams, we might not have enough plates for everyone. So we're going to serve to the imams first, and if we have extra, then we'll serve out to everyone else. Also, for the imams, please pick up your certificates because this certificate is specifically for this training. We do want you guys to, get awarded for being here. So please pick up your certificates before leaving. We're going to have them outside on the registration table, all laid out, so you can just grab yours. All right, thank you.
Sorry, I have a quick comment that's geared toward the imams, if I could get their attention, please. Especially in the Arab and Muslim community, I've been trying really hard to bring awareness to the drug problem for the past several months. Recently, on Monday actually, there was a Detroit News article written about me which quoted me and another young woman talking about the problem that we had within our family. And I would just like to state that generally there's a lot of support for anyone doing anything against the drug problem or an anti-drug campaign. But the families that are affected, that have like an addict in their family, are generally the most resistant and the ones that will try to keep everyone quiet. So what I'm trying to say is when people have someone that's addicted in their family, they know. So the signs and symptoms, they already know that their brother, their son, or there's something wrong with that person in their family, but the problem is they're not seeking help. So what I'm asking the imams to do is to encourage people to speak up as soon as they know, because nobody's gonna know. You're not gonna know as an imam, but the mother knows, the brother knows, the sisters know, but they're not talking about it. They're too embarrassed. And actually, when I talked about it, my cousin's, the brother to the one that passed away last year, he was the first one to say, yes, we do have a problem and we need to help. But my colleague who also spoke up, her family was very upset that she brought it up and brought shame to the family. So we need more people in our community that are not ashamed of the problem so that we can change the face of addiction. That's one of the things that FAN talks about, is changing the face of addiction. And hopefully, inshallah, we will bring FAN to the Muslim community, to the Dearborn community specifically. But we have faced a lot of challenges. And I just wanted to encourage you to, when you're speaking at the sermons, to let people know that it's okay to speak up, but we have to change our culture so that it's not stigmatized and not taboo to have someone in our family who has a drug problem, because addiction is a disease, and it's not something that the parents did wrong. Thank you.
Yes.
There's one person in
I just want to thank the judge for giving credence to the community and the families who can do better than the doctors and the nurses. I'm a physician myself, and I worked with Harvard Institute of International Development for 3 days. And I'm talking about Pakistan. I will just give you a simile. 5 million people, children were dying of diarrheal diseases and dehydration in 93 when I was working, every year. It's still 2 million. We tried to go and promote the oral rehydration therapy amongst the doctors and nurses, but they all wanted them to put them in the room and put a drip in. When we started talking to the mothers and the grandmothers, where the literacy rate is only 36%, they did better than the doctors to promote the oral rehydration therapy, and we saved 80%, the mortality rate went down by 80%. So I give you credit for being the mother, and I give credit to the community that they know. I always tell my patients, I am a pediatrician. I always tell the mothers, you are the real doctor for your child because you know your child better than me. I see your child for 10 minutes, and I tell my residents whom I train, listen to the mother. She knows what is wrong with her child. So getting the community, the mothers, the daughters, the sisters involved in the treatment and understanding the treatment is a great step. And I really thank you for that.
Thank you very much.
Assalamu alaikum warahmatullahi wabarakatuh. Peace and blessing be unto you all. Thank you very much for your insight. I'm a practicing physician for over 20 years. I have seen everything. And for last 3 years, I've been treating addiction. I've been certified in addiction treatment. My question to you is the legislation, when your physician is certified for addiction treatment, as you said, people are dying every 12 minutes, and you get only 30 patients for the first year of treatment, and after that you have a quota of limitation for treat only 100 patients max. I don't understand what kind of people are dying like a flies, and you have a legislation that you have restriction for 100 patients at all for addiction treatment physicians who are certified.
I couldn't hear what you were saying. What was it?
Yeah, for Suboxone treatment for heroin addiction. I've been treating for heroin addiction for last 3 years.
Yeah.
And you have a limitation for legislation for first year when the physician.
Yeah, they're going to lift that. There's legislation pending right now that's going to be more regulated, and they're going to give you a lot of guidelines on like the potency of the Suboxone that you can use, but that 100-person limit that you have right now is going to be lifted.
I've been practicing for 20 years. I can write morphine, oxycontin, unlimited, but when I want to treat the heroin addiction, you have a restriction.
Yep, it's changing.
And there is no enough counselors available. There is no enough physician, no enough facilities available.
Right.
And my question also is, I have a patient who do this drug problem, they go to jail, and they said they get more drugs in the jail than outside. And what kind of broken system we have here?
The system is broken at so many levels that, believe me, sometimes I wonder if we'll ever get it fixed. But we just have to be doing what we can, the best we can. But if you hear those things, you should be calling your sheriff and letting them know that there are drugs in. We've really worked with our sheriff, and I'm not going to tell you there are no drugs there, but they do a much better job now of
in all our teenagers I've seen from 17, 18-year-old to 40, 50-year-old, they are involved in these drugs. And the root cause is, as you know, we have a broken families. We have a single parent who raising the children, they're doing the 2 jobs, nobody's watching the kids, and kids are getting influenced by bad influence outside.
Right.
No wonder all our jobs are going to outside the country because we have no skills. People are busy in heroin, believe me. So we need to correct the root cause of this problem with the society.
Right.
Thank you.
I believe this gentleman right here had a question. He has a question too. Oh, I'm trying to get you. Okay. Okay.
A couple questions. One, if we have, for instance, older people who have chronic pain that cannot take ibuprofen due to kidney issues, what resources do we have to read up on other medications that they can take so that we're informed when we engage their doctor as to what their prescriptions are, if there is such a resource?
You're going to see a big change in what doctors are doing because they're coming up with new protocols all the time of what's appropriate for doctors to do and what's not. But if somebody is already dependent on narcotics, there is going to be a withdrawal, but there are drugs to help them withdraw with very little pain. They need to get off the drugs to see what they really need. Sometimes there's more pain caused by the withdrawals. Your pain actually exacerbates when you're taking opiates, and it feels worse than what it is. And so you have to be off of them for a period of time to tell whether or not you've healed. But because it masks pain, sometimes you re-hurt yourself just because you can't feel anything. So it's a really complex thing, and unfortunately, it's very difficult to get elderly people off of these. But I have worked with several elderly people that have done it after they realize what they're on, and they've been very successful with it. It's just a weaning off process and a detoxing process. Okay.
The second question I have is there a correlation between the war on Afghanistan and heroin supply?
Is there a correlation?
A correlation between the war in Afghanistan and the supply of heroin here in the United States?
I can't, they're talking and I can't.
Is there a correlation between the war in Afghanistan and the supply of heroin in the United States?
Okay, I got the heroin thing at the end, but is there a correlation?
Is there a correlation between the war in Afghanistan and the opium supply in the United States?
A lot of people come back addicted from being in Afghanistan, so it certainly adds to it, but it really has gotten so much more complex than that. Most of our opiates are coming from Mexico at this point, not Afghanistan. It used to be that was our biggest supplier. That's no longer true. Okay. Yes, sir.
Thank you, Judge, for very interesting information that you shared with us this evening. So what is the logic of legalizing the marijuana? I mean,
you'll never get me to say that it's logical to legalize anything. Okay, so let's be clear with that. I think if you look at the states that have legalized marijuana, they are creating a whole new level of problems with their young people because it's not regulated. It's even the medical marijuana here. It's one of the biggest things that I have to deal with on a daily basis. Is marijuana is 20 times stronger than it was when I was a kid. So it's very, very strong. It's laced with all kinds of things because it's not produced anywhere. People grow it in their homes. And so you can add anything you want to it when you're selling it. And I will tell you, I run a drug court in my court. I've had an easier time getting people off of heroin than I have off of marijuana. So I'm not supposed to comment as a judge on legal issues like that, on what my opinions are, but I think we really need to talk to our legislators about that one. Okay.